I wanted to introduce our speakers. This is our next installment of our Pediatric Heart Center Research Symposium that we hold monthly. Just some housekeeping things. We are not going to have one of these in July. We're going to take a summer break, but we will be back in August with Rebecca Kameni and Sanjeev Datar, who will give the talk in August. So no talk in July, but we will be back in August. And our talk this month, we're very fortunate to have our two speakers today. We have Dr. Greg Kurio, who's an associate professor of pediatrics, who works predominantly over on the Oakland side in the Pediatric Heart Center. And then we also have Dr. Amy McNelis, who's an associate professor of pediatrics, who's in the Division of Hospital Medicine. And they are going to be speaking to us about the Beyond Fever hot topics in Kawasaki disease.
Yeah, sounds good. Thank you. Hi. So I know many of you are in the cardiology group and probably very familiar with Kawasaki disease, but I'm just going to briefly and our objectives today are really to discuss the research studies that we're involved with, and particularly the KIDCARE trial. But I just want to take a moment to make sure that learners of different stages understand what Kawasaki disease is and just briefly go through the criteria. So as many of you know, the original case definition was fever for 5 or more days. And as a note for that, we count the first day of fever as the first calendar day. There we go. Okay. It's okay. And 4 of the 5 following criteria: conjunctival injection, which represents a uveitis rather than an actual conjunctivitis. Clues are that it may be limbic sparing. It should not be exudative. Cervical lymphadenopathy, which is the least common of the criteria and at times can be the presenting finding. Mucosal changes, which can include erythema and swelling of the lips, strawberry tongue, and other changes. These are also seen in many other diseases that we take care of in pediatrics, including group A strep, Stevens-Johnson, and even paraneoplastic pemphigus. Should not include oral ulcers or an exudative pharyngitis. Rash, which many of you know is very nonspecific. Some clues it can be Kawasaki disease is that it may be more pronounced in the perineum. It should not be vesicular. Then the extremity changes, which are helpful when they're present because these are some of the more specific findings that we see. So just again, for the learners that aren't as familiar with Kawasaki disease, for classic Kawasaki disease, we should see 4 of the 5 criteria. For incomplete, you should consider with 2 to 3 of these criteria, and then use your algorithm, which is in the 2017 guidelines. Also, just as another note, also consider incomplete Kawasaki disease in infants with unexplained fever for 7 or more days. So just again, briefly going over the timeline of Kawasaki disease. It was first described in Japan by Dr. Kawasaki in 1967. In 1974, the first cases were described in the US. We know that untreated Kawasaki disease has a 20 to 25% risk for coronary artery abnormalities. In 1984, the benefits of IVIG were first described, and there's clear evidence that the first dose of IVIG reduces the coronary artery abnormalities down to somewhere between 2 to 5% in treated children treated by day 10. For patients who have persistent fever or recrudescent fever 36 hours after the completion of the first dose of IVIG, we consider this IVIG resistance. And this occurs in 10 to 20% of the population, patients treated for Kawasaki disease. We know these patients have a higher risk of coronary artery abnormalities with a rate of 12 to 15%.
It's going to be a lot like watching the Academy Awards when people are fighting to see who opens the envelope. So if you are among this group of IVIG-resistant Kawasaki patients, what are our options moving forward? I mean, obviously, the inflammation is still going on. They are at risk for coronary artery aneurysm. So looking at our basic armamentarium, I think one of the more common things is second dose of IVIG. That I think has been, it certainly was my practice when I was working as a hospitalist before cardiology, and I think that it's still a fairly common practice. We can do steroids. That is a very controversial topic. If you do a literature search on that, you will see very varying protocols, very varying results. Ulinistatin is kind of a strange drug that was tried in the mid-aughts, and that's a urinary trypsin inhibitor that seems to reduce inflammation on various avenues along the cascade. Infliximab, which is anti-TNF alpha, anakinra, which is an IL-1 receptor antagonist, cyclosporin, which is calcineurin inhibitor, and cyclophosphamide. And really, the common thread here is modulating the immune system against this immunologic problem. The second dose of IVIG, again, the more common thing, people have espoused maybe using a different manufacturer. I've heard that anytime you have an IVIG, which is, you know, a purified blood product, we're looking at just the IgG moiety of it, you're probably looking at the immunologic history of about 200 humans that went into it, and maybe using a different manufacturer, maybe using a different batch, you'll get a different antibody profile, and that may be the bullet that needs to take care of the inflammation of Kawasaki disease. And, well, some people say, well, why would you give a second dose of IVIG? You already know they're resistant. So I don't think common wisdom says it's Einstein who said this, but you know, the definition of insanity is doing the same thing over and over again, expecting a different result. So maybe that isn't the way we should be going, and that's kind of the segue to what we're doing with our study that both Dr. McNelis and I are PIs for on our sides of the bay, and that's infliximab as second-line therapy for Kawasaki. The timeline of the medication is in 1998. You guys probably know it better for Crohn's disease, rheumatoid arthritis, that sort of stuff. It came out in 1998 as approved for Crohn's disease. And then in 2001, the Japanese were ahead of us in terms of the other use of infliximab, but it was approved for Crohn's disease in that country in 2001. The first description of using it in Kawasaki was in the Journal of Infectious Disease in 2004. And also in 2004, the Kawasaki meeting for the AHA came to San Diego, and many centers, we kind of talked about what our experience was using infliximab, just sort of off-label use. So Boston talked about it, Denver, San Diego, of course. And then in 2004, Centocor put out an actual study, and Dr. Burns, Jane Burns at UCSD, published those results in about 2005. First case report in Japan was 2006. And then, well, pediatric Crohn's disease is not part of our talk today. But the phase 3 study in KD in the US, which is an NIH-sponsored study, was 2008. And the Japanese did approve it for use in 2016. So what we're looking at now is the KIDCARE study. I'm going to turn it back over to Amy to kind of talk about what we're doing on both sides of the bay here.
Yeah, so KIDCARE is the acronym for Kawasaki Disease Comparative Effectiveness Trial. And it's a comparison trial of a second dose of IVIG, which now is one of the options, versus infliximab for IVIG-resistant patients. So that 10 to 20% of patients that still have fever 36 hours after completion of the first IVIG. So infliximab is a chimeric monoclonal antibody. It binds TNF-alpha with high affinity and specificity. We know that TNF-alpha levels are high in the plasma of patients with Kawasaki disease, and these correlate with the development of coronary artery abnormalities. So in our study, the patient is randomized to either receive a second dose of IVIG, same dose of 2 grams per kilogram as the first dose, or infliximab at a dose of 10 milligram per kilogram. And the slightly higher dosing is used to bind adequate TNF-alpha in patients with Kawasaki disease. This is a schematic of the pathogenesis that's proposed in Kawasaki disease. And the calcium signaling pathways are thought to be central to the pathogenesis. You see TNF-alpha down here, and we know this is associated with inflammation and the development of coronary aneurysms in Kawasaki disease. So the goal of the study is to determine whether infliximab versus a second dose of IVIG abrogates fever faster and is associated with fewer adverse effects in IVIG-resistant patients with Kawasaki disease. The primary outcome measure is fever at 24 hours after initiation of the study treatment, and that they remain afebrile with no recurrence for 7 days after discharge. Secondary outcome measures include the following. We're looking at SED rate at diagnosis, as well as 2 weeks when they follow up with cardiology. And this is just one marker. We do know that IVIG can affect the SED rate, so it's just one secondary outcome measure that's being evaluated. An important one is the change in the largest internal diameter of either the right coronary or left anterior descending arteries between the initial echo at baseline and the 2-week follow-up. Other secondary measures include the following. If they are afebrile at 24 hours after completion of the study drug, whether this is IVIG or infliximab. They're afebrile 7 days after discharge. We're also looking at therapy-related adverse events, including hemolytic anemia, which certainly can occur with IVIG. The requirement for additional anti-inflammatory therapies after crossover failure, the total number of fever days, as well as duration of hospitalization. Other changes, we're looking at the CBC and all these parameters, the white count, ANC, hemoglobin platelet count, and CRP. So both the CRP and the SED rate are being evaluated, as well as parent reporting outcomes. And I'm going to go over a little bit what questions parents are being asked, both during the hospital course and after they leave the hospital. There are 30 sites, which I will show you in a moment. The central IRB is with UC San Diego, and Jane Burns and Catherine Kim at UC Davis. Jane Burns at San Diego, obviously, and Catherine Kim at UC Davis are the co-PIs. These are the West Coast sites, and the numbers, this is to date as of April. See, we are down here. We are relatively low in number of total KD diagnoses, although that will increase. For May, we actually had 3, which has been our highest number yet. So that will increase. We have only had 1 IVIG resistant patient, and again, we would expect about that number to be about 10 to 20%. I suspect this number is low. You know, it's interesting to look at these numbers, just looking at other sites. I think part of the reason that our numbers are low here is that some of these kids are being treated in our community hospitals. I know many of us will get calls, from some of the community hospitals we're affiliated with, and they're being treated there. So I think that's some of the reason that we're having lower numbers rather than inadequate diagnosis. These are the East Coast sites, so you get an idea of the centers involved. Emory has particularly high numbers, as you can see. Also, it's interesting to look. We suspect the IVIG resistance to be higher, so we're trying to, with the group, trying to sort out are all screen failures being reported. This is to date as of April, the different sites and the number of patients enrolled across the 30 different sites. And then this is the study design. So here is, here's our initial KD diagnosis, where they receive the first dose of IVIG, 2 grams per kilogram, as well as aspirin. The aspirin dose does not matter in this particular case. I will just make an aside. You know, many people are familiar with the 80 to 100 milligram per kilogram per day high divided Q6 high dose aspirin. Many KD experts in the US, including amongst our group, the consensus has mostly been to use more moderate dose of 30 to 50 milligrams per kilogram per day divided Q6. That's based on less toxicity and no difference in outcomes, so, but does not matter for enrollment in the study. Next step, so, and at baseline, they'll have their baseline echocardiogram, CBC, CRP, and SED rate. For if fever persists 6 hours to 7 days after the first IVIG, they would be eligible for the study. Inclusion criteria are the ages are 4 weeks to 18 years are the age groups. The exclusion criteria are mostly other treatments. So steroids would be an exclusion criteria, other treatments if they happen to receive other adjunctive treatments for primary treatment that would exclude them, or high risk for TB, including any concern for TB. So after we discuss the study with the patient and after informed consent obtained, they would be randomized through a red cap system to receive either a second dose of IVIG or infliximab at 10 milligrams per kilogram. And then there are also parental reporting outcomes that I'll show you in a moment that occur in the hospital. So at baseline, at the start of treatment, at 8 hours, 16 hours, and at 24 hours. So the primary outcome, again, is that they are afebrile at 24 hours after the initiation of the study treatment, as well as the secondary outcomes would include looking if they're afebrile at 24 hours after the completion of study treatment. If they are not, they would cross over to the other treatment. Then return for cardiology follow-up at 2 weeks, where the second echo, as well as CBC, CRP, and SED rate would be done.
Let's take I-80 East.
So these are the parent observation ratings, and the just reports from patients that have been enrolled thus far across the different centers has been very positive from the parents reporting these. So they're giving check boxes, but can also free text. So these are ones that occur both in the hospital at the start of treatment, at 8 hours, 16 hours, and 24 hours. And then at the time of discharge, they're given the option of completing these by paper or by email, and they're contacted by the group at UC Davis for the email, and then parents will continue to report these daily and fill out these forms for the next 2 weeks. In addition to the ones here, which are the inpatient ones, they'll also report on fever, cold symptoms, vomiting, diarrhea, and other illnesses. I'm going to sidetrack. So that's the basic. We don't have a lot of data to present, unfortunately, at this point in time. We're pretty early. It's a 3-year study, and we're not quite a year into it at this point. So I'm going to go through a case that I like to talk about just because it's one that actually was seen at Children's Oakland, but we also took care of it in our cardiac ICU here. So it's an 11-year-old previously healthy male who presented with fever with associated nausea, vomiting, and diarrhea. He rapidly deteriorated and was appropriately treated for presumed septic shock. He eventually required high-dose inotropic and vasopressor support and mechanical ventilation. The initial echo showed severe biventricular dysfunction consistent with cardiogenic shock. The follow-up echo 10 days after the first and 14 days after the onset of fever showed new coronary artery aneurysms. The left main coronary artery had a Z-score of 2.39, the LAD had a Z-score of 3.16, and the right coronary artery a Z-score of 3.30. I think this looks like mostly a cardiology group, so you guys are probably familiar with the Z-scores. I'm just going to take one moment for those of you who are listening. The Z-scores are the luminal dimensions of the proximal segments, which are adjusted for body surface area. And for those of us who care for these kids inpatient, it's really important that we measure the height and weight accurately, and the height especially, since it's often challenging in an arable, fussy infant to get an accurate height. Z-score of under 2 is no involvement. Dilation only is 2 to under 2.5. Small aneurysms are greater than or equal to 2.5 to less than 5. Medium aneurysms greater than or equal to 5 to less than 10, and giant aneurysms greater than 10. So this was KD shock syndrome, and we've been interested in it just because we had this patient we shared, but Greg's seen a number at Children's Oakland as well. It's interesting in that observation of occurring in clusters is something that's been noticed before. San Diego's had the same experience, and we've all seen more than we tend to see in other years, and there's some years that it just isn't seen. So one study out of San Diego with Jane Burns and McConaughey, these were the findings. They actually prospectively looked at all patients with Kawasaki disease, and these are some of the findings, and I'll go over the data in a moment. So their rate was that they found it occurred in 7% of the patients with Kawasaki disease. Other reports have been in the range of 5%. As I mentioned, it tends to occur in clusters. They tend to have more severe laboratory markers of inflammation. They are at greater risk of coronary artery abnormalities, and I'll show you those numbers in a moment. They're at higher risk for mitral regurg, greater risk for prolonged myocardial dysfunction, and at a higher risk for IVIG resistance. So remember, the IVIG resistance rate is generally 10 to 20%. That's the patient population we're studying in the KIDCARE study. But in this population, it was 46%. So these are some of the patient characteristics of KD shock syndrome versus KD without shock. And their definition of shock, so they use pretty standard definitions of shock, with systolic hypotension, poor perfusion, but they also used a decline in systolic blood pressure of greater than 20% from the baseline. All these patients had fluid resuscitation. The mean was 53 milliliters per kilogram. About half, 54%, required vasoactive infusions, and the mean duration was 68 hours. So the numbers, the significant differences were more often female. They had a higher proportion of bands. CRP tended to be higher in the Kawasaki disease shock syndrome group, and tended to have a lower hemoglobin and platelet concentration, including 45% had evidence of DIC based on laboratory values. There are no significant differences in age, duration of illness, for example, days of fever at the time of diagnosis. Looking at the echo results for the acute phase, and the acute phase was defined as the first 10 days, so the baseline echo in the first 10 days. They found impaired left ventricular systolic function with low ejection fractions were more common in the KD shock group. Mitral regurg was also more common. The coronary artery abnormalities were more common with the max LAD and right coronary artery Z-scores were higher in the KD shock syndrome group. They also, just to note, there was no aortic regurg or pericardial effusions in these groups. And I'm going to hand this over to Greg in a moment to explain some of this, but these were more long-term measurements. So echo 1 was, again, in the first 10 days during the acute phase. Echo 2 was subacute, so days 11 through 21 after diagnosis. Echo 3 down here was in the convalescent phase, so from days 22 to 90. And then the last echo, echo 4, was more chronic, so days 91 up to 1 year after diagnosis. And interestingly, they found significant abnormalities in the diastolic function in the Kawasaki disease shock syndrome group, with impairment of ventricular relaxation and compliance, and these persisted on the follow-up echoes.
So just to kind of give you a synopsis or a summary of the patients that we were seeing over in the East Bay side, I noticed the ICU people among us perked up when I said, you know, inotropic support, et cetera. But we have seen probably 4 or 5 cases this year, and like Jane Burns was describing in the 09 paper with John Kanagai, they tend to come in clusters, and we're seeing a cluster. I don't know if this has anything to do with it, but they seem to be from the North Bay area, at least looking at their area of follow-up. But we have had not just this child, which we shared, but another 8-year-old child with pretty severe shock, needing epinephrine, norepinephrine, arginine vasopressin support, and she had fairly sizable aneurysm. So this is definitely something that is different about this year's Kawasaki cohort, and we're going to kind of put our heads together and try to figure out why. They're going to assemble, or one of the cardiologists over at Baylor is assembling a registry to kind of look at KD shock. So this is, for all the cardiologists in the room, by no means a complete assessment of anybody's diastolic function or dysfunction, but this is a highlight of what abnormalities they were finding in the 09 paper. I haven't dived into our patients yet, but I assume once we kind of get the ball rolling with the folks in Baylor that we will be looking at these parameters as well. It's interesting to note that really we're looking at the second and third echocardiogram, so you're looking at 3 weeks to 3 months after the diagnosis. Everything else does not really reach statistical significance. And without belaboring too much the phases of diastole and what we're measuring here, these are basically Doppler evaluations of either the inflow of the mitral valve or the actual tissue, the annular tissue of the left ventricle, and saying there is some component of delayed relaxation of the ventricle. The ventricle is not able to accept the adequate volume or a normal volume at a normal left atrial pressure. There is something going on with the stiffness of that chamber. And that kind of segues into something outside of KIDCARE that we're looking at or thinking of looking at over on our side is there a way to do MRI evaluation of convalescent KD? Should we have a comprehensive cardiac MR protocol? And I'm lucky enough to have good support over there, Dr. Chung, who's helping me out with quite a bit of this. And it seems like the things that we are interested in with Kawasaki lend themselves very well to MRI evaluation. For instance, imaging of coronary arteries. While there are possibly more precise or better spatial resolution ways to do it, we're doing, I think, a very, very good job over in the East Bay, mostly thanks to Dr. Chung's techniques at looking at coronary arteries, coronary artery aneurysms, looking at, you know, correct me if I'm wrong, 0.6, 0.7 millimeter in-plane resolution, which is quite good. So we can look at the coronary arteries, look at aneurysms, look at areas that are beyond what we typically see by echo. We can obviously look at ventricular systolic function. We are looking at the entire myocardium without regard to windows that sometimes limit us by echo. So we can actually look at segmental wall motion abnormalities. We will look for gross scar if you have a big aneurysm and we suspect that there was some sort of occlusion ischemia. We can look at gross scar by the usual late gadolinium enhancement techniques. A couple of other things that are at the bottom that we're looking at and working on. There is a way to, in a more quantitative manner, look at the amount of fibrosis in a myocardium that's not affected by other infiltrative diseases, and that's an extracellular volume enhancement assessment where we're looking at gadolinium enhancement, but you're actually looking at a T1 score per pixel, so you should be able to quantify the amount of fibrosis. It's good at looking at what I've described it as in the IRB is I'm looking at kind of the dark matter of the myocardium. I know it's there, but now we have a way of possibly quantifying it, and that may lend itself to stiffness, diastolic dysfunction, et cetera. And the other thing we're looking at is left atrial volumetrics. We've kind of looked at right ventricle and left ventricle volumetrics, but is there a way to look at many of the same parameters that we think about by echo, but is there a way to look at how the left ventricle is filling or how the left atrium is emptying and get an idea of what the diastolic function is as part of this comprehensive examination? So the images that you'd acquire would kind of look like this, ideally, and this is kind of our right coronary, 2 different patients, right coronary imaging, which, you know, it's probably not as spatially precise as a CT, but really you kind of get you get a good sense of the caliber, the length of the dilated segment. This child is a little under a year, and granted that was with anesthesia, but I think the results are quite good for the size of child and what we wanted to do. The volumetrics, the cine that you guys are used to seeing. This is the extracellular volume assessment, and basically the colors are kind of a personal preference, whether you like warm color palette or a cool color palette, but the colors kind of help us look at what that pixel scored in terms of the T1, and therefore the amount of enhancement there. And this, I understand that it is in the context of myocardial iron toxicity, but this is actually something that we had published with some colleagues in Hamburg looking at the emptying of the left atrium in the ventricle, and is that a better way of looking at the stiffness of the ventricle by the volume that's coming into it from the left atrium. So that is what our dream of a comprehensive cardiac MR for the evaluation of convalescent KD would look like. We're kind of going at it piecemeal. This stuff we already do very commonly. This stuff we're working on right now with the 3 Tesla magnet, and we're just gathering data on it, but as you saw from the iron overload studies, the preliminary data actually look pretty promising. And then there's the question of, and if you read a lot of KD, you've seen, well, you know, there's edema, there's inflammation. So is there an application for something like this in acute KD? For me personally, I think that the age of the patient, what therapeutic benefit you will get from something like this probably makes that not something we are going to do, because this study can take a while and will require sedation in a patient for no real therapeutic endpoint. Like, there's nothing I would see on this that says give this drug. So I'm not sure that's really in the cards for this. But for the long-term care of the Kawasaki patient, I think this is very promising. And we are seeing more hints that diastolic dysfunction is a big problem for these patients. And for those of you that know Jane Burns out of San Diego, she's married to an adult cardiologist, and John Gordon is kind of tagged along with a lot of the Kawasaki studies looking at these adults that had Kawasaki's years ago and looking at their left ventricular and diastolic pressures. And yeah, so hopefully there'll be applications there. Just quickly, looking at time. So other projects that are out of Japan, you saw the list of salvage therapies that are possible. The Japanese are looking at something in particular. They're looking at cyclosporin. We're using it off-label every once in a while, and the San Diego group actually is using it more commonly, but really not enrolling them in any study. So the Japanese are doing cyclosporin, and as we talked about earlier, it's a calcineurin inhibitor. I'm going to put that schematic that Amy showed you earlier up to show you where that effect is. But it basically modulates the immune system on a variety of levels and gets us out of that bad inflammatory cascade, working on IL-1 and TNF-alpha before they are released in large quantities. And there is some evidence that it expands the regulatory T cell population, which sort of calms everything down and not let it get so out of control from cell to cell signaling. So here's our diagram again. So your cyclosporin is going to work here. Calcineurin signaling from this calcium-sodium exchanger and into our activated cell, and hopefully modulating the TNF-alpha IL-1 pathway, decreasing our inflammation, decreasing our risk of aneurysms. And the Japanese, not to be outdone, taking liberties with the English language, Kawasaki disease study to assess the efficacy of immunoglobulin plus cyclosporin A somehow gets made into KICA or KISA. But then again, we took a lot of liberties with KIDCARE too, so we can't really talk. But that's what they're going to do. And so there are a couple of things that are already out there in terms of looking at cyclosporin in the treatment of Kawasaki, one out of Japan, one from our colleagues down at San Diego. So KAICA, or KAISA, I don't know how they're pronouncing it, 18 centers across Japan, they're going to randomize the high-risk KD patients to two arms, either standard therapy plus cyclosporin or standard therapy alone. So this is going to be an additive primary treatment for Kawasaki, and they're just looking at coronary artery aneurysm incidence. Oh, I didn't delete that. So other projects that we are looking at, not at UCSF, but at UCSD, Dr. Burns is able to randomize people to either atorvastatin and placebo or anakinra. And if you remember our first slide for salvage therapy, that's the IL-1 receptor antagonist. And they are working on that, in case you're wondering. The atorvastatin threw me for a loop too when she told me about that, but it does interrupt signaling both at the myofibroblast level and the cellular pathway at the same calcium-sodium exchanger. And there is some preliminary data that it reduces inflammation enough that it can mitigate coronary artery aneurysm formation in Kawasaki disease. So acknowledgements, I think the first acknowledgement should be Dr. McNelis, who is actually on service for general pediatrics and came to give this talk, and I am thankful and very impressed that you could do that. Obviously, Dr. Burns, Dr. Tremolay that are on the KD team at UCSD, Dr. Taylor Chung, who is basically my MRI brain, makes me seem a lot smarter than I am. Samantha Roberts is our administrator for the KIDCARE study, and then the rest of the KIDCARE investigators in the 30 sites across the nation. Did I miss anything? Okay. So I think that wraps up what we wanted to talk about. I'm happy to take any questions about any of the stuff that we discussed here.
Hey, Greg, that was great. I had a question about the protocol. So for the patients who have a recurrent fever, they get crossed over and redosed like 24 hours later or something like that.
Yep.
How are you figuring out for those kids in the long-term outcome on the coronaries, whether it was the IVIG, that what was impacting the end result if they're crossing over to the other therapy?
I think that if they cross over, necessarily they're still febrile. So the thought is that whatever you tried before, if it just hasn't adequately mitigated the inflammation. So for the long term, at which point they become afebrile, whether you go on to use other medications, you'll have to say that the last thing you used that rendered that patient afebrile was probably the thing that made the difference. I realize that's an assumption, and there's gray areas here where you can use. People have used 5 milligrams per kilogram of infliximab, but that may not be. There's a bunch of data that says that may not be sufficient to sop up all of the inflammatory mediators that we need, and that's what's causing the prolonged inflammation. So yeah, it may be a combination of all the things that are dropping the inflammation down to levels that we're not concerned about anymore. But the assumption is whatever you gave last, I think, is going to be.
That was a great talk. Thank you, Greg and Amy. Just a quick, the patients that have KD shock syndrome or even the IVIG resistant patients, has there been any reports on sex or racial ethnic differences in those patients that can eliminate?
Yeah, and in the KD shock, there was, most of it reflected the population in San Diego. There was a higher percentage of Latino patients, but that mostly reflected their demographics in San Diego.
I was struck by that, how many girls they had.
Yeah, and then the girls, there was a significant difference with the girls.
Because if you look at, we don't use them here, but the Japanese love their risk scoring, and there's a Harada score, a Kobayashi score, a Gami score, and a couple of them, I think it's the Harada score that says male less than a year is high risk for coronary aneurysms. And it seems like their 09 data didn't reflect that.
Right.
And it seems, I don't know what your experience has
And those
been
were
this year.
years, I think the study was like 2003 to 2007 for And in Taiwan, it's, you know, it was, I think the interesting thing with the patient that we shared, the 11-year-old, and when he was older, and then two, the prominence of the GI symptoms when he presented. There was one study I found, it was really small, it was mostly case reports, but a number of those had GI symptoms too. That wasn't what they found in the San Diego group, but sort of interesting.
Our shock patients have been, I feel like they've been older over on the East Bay side. So we had the 11-year-old, the one with the aneurysms that needed the multiple inotropic therapies. That girl was 8 or 9. So yeah, I feel like they've been older.
Right, and it was interesting, then the San Diego group, they weren't, they tended to be actually on the younger side.
And we always say
Yeah.
males, young, that's
Yeah.
a bad
Right.
KD patient. So, you know, but it definitely clusters. So hopefully something will come out of Dr. Tatel.
Title, yeah,
Tables.
we were trying to get it more, and if anyone
The
is
Baylor
interested,
person.
we have the contact information for the person, Texas program, who's doing the KD shock syndrome study.
But I think that's definitely going to be a good project to go forward with. Anything else? Thanks for coming, guys. Oh, I'm sorry.
KD shock kids, so most of them are gonna come in with a myocarditis picture, so they're gonna get IVIG independent of making the Kawasaki's diagnosis, but the aspirin's most likely not gonna get started early. Is that a big player for the importance of getting the aspirin going in those patients that have atypical and a late diagnosis?
Aspirin's an interesting question, and I don't know what your experience with this has been, but I feel like I went to medical school in Hawaii, so Marion Melish was my ward attending. So I feel like between the time I was a student on the wards and now, the administration of aspirin and the dose, and that's changed so much. We used to give it for like, I don't know, a few weeks at high dose. They had to do it at home. They had a lot of GI upset. So, there's a dearth of data on it. Nobody's really going to try and give aspirin without IVIG. So I think the guarded response has to be probably doesn't make a difference because we don't really know what the contribution of the aspirin to the eventual outcome is going to be. Maybe it's just taking care of the sticky platelets, which are just an acute
Really
phase.
highly
Yeah.
inflamed kids that we've been seeing before there was even Kawasaki's. Some of us were practicing medicine, and these kids were, just coming in and they were highly inflamed, and we didn't know what was wrong with them. We certainly didn't know anything about coronary artery aneurysms. They don't absorb the aspirin very well anyway. So you're getting the downside without getting the upside. They stay febrile. They don't do well. So, in my opinion, that's not very important. And when it becomes important is when your platelet count starts going really up and gets near the millions.
And that's when you stop that
We didn't
because they're
present
no
the
longer
space, there
febrile.
are numbers from Japan and Taiwan that really show no difference in effect with the moderate dose compared to the high dose. And that's what's been used there for some time, as well as most countries in Europe. And that's what, we have, it's nice with these meetings, we actually have monthly discussions and, go off topic from KIDCARE and often present sort of just questions we have as a group. And really, the consensus has mostly been for people going to moderate dose of 30 to 50.
I think
milligrams
30 to
per
50 is
day.
going to be pretty standard in the next
I know
year or
it's
two.
vague in the guidelines,
Yeah.
but it allows for either, but most people.
But it's purposely
yeah,
vague.
yeah.
If you talk to the people who wrote the guidelines, they're like, well, we leave it open because we're probably going to say that 30 to 50 is sufficient. Yes. Thanks for coming, guys. Matt?